CataractCoach.com, the Best of Cataract Coach course from the ASCRS in Boston 2024. All right, case one. The posterior capsule splits wide open, so watch carefully. This is a routine case that I'm doing. You can see not very dense cataract, a lot of posterior subcapsular cataract. I'm operating, it's not a resident. So all the videos today are gonna be a little bit sped up so we can get through everything fast, but it's a routine case. I wanna show you I got a nice rexus done. Really, that's not the issue here. Got good draping, the eye's pretty good primary position. I'm gonna get the nucleus up out of the bag. You can see that's like Beverly Hills style, it's not too dense. This can be emulsified very easily. That's not the hard part. That's why we're going really fast through this part. The issue here is gonna be in cortex removal. And I find now that, after tens of thousands of cases, that's usually the issue. So watch carefully, let me slow down the video here. I wanna clean up the capsule, get the cortex. Now there's a little smudgy stuff, some little fibers down there on the posterior capsule. So let me just kind of vacuum those right there. Almost. A little bit more on the other side. Polymer tip here, nice soft tip. Maybe if I go from this direction, I can just get it right there. There we go. Now I feel better.
Wow.
Now I feel really good.
That's a really clear posterior capsule.
I know, but they had that thing right there. I couldn't leave it.
Now that you moved it out of the way, it's really clear.
You took care of the issue.
But you wouldn't have gotten that little piece?
No.
What?
No.
Oh, well.
No, I was waving to you. You have to get it.
You have to get that thing.
Yeah.
But there is visco.
Okay, so what's your next move? Blame the scrub tech, the nurse, and the anesthesiologist. It will be fine, just plow ahead. Pull the eye probe out of the eye to evaluate, keep the eye probe in the eye, put this glass. What are you gonna do here, and why?
D.
Okay, but why?
Because if you do, well, you could blame somebody else, but if you pull the IA probe out of the eye, you'll get vitreous coming forward. So you want to maintain pressure in the
right. If you do that, you're going to have shallowing of the AC pressure goes to zero, vitreous comes forward, and it's a hot mess. So you wouldn't just plow ahead, I guess.
No.
So is there a type of viscoelastic you prefer in this case? A dispersive, a cohesive? Does it matter? Or just take whatever's in the tray? What are you going to do here?
Dispersive. Because you want to compartmentalize. So keep the vitreous back, and then figure out what you're going to do next. But yeah, definitely do not pull out of the eye.
So as you inject the viscoelastic, do you come like off your paddle, then take the infusion off too? Because how do you prevent yourself from washing out the viscoelastic?
Exactly, and this is a super important thing that you need to practice before you have a PC rupture. So when you're about to put the IOL in, I do it at that time. When I finish the cortex removal, I practice putting the viscoelastic in and decreasing the irrigation, and then you fill up the bag and you come out. So this way you practice with your left hand,
for sure.
and you're one step ahead.
So position one on the pellet going to zero while you inject.
Yep.
All right, cool. So let's show you what I did here. I listened to your advice. So here comes the dispersive viscoelastic. I'll start to inject it, and if you just stay in position one, what's going to happen is you'll just wash it out. So I'll now come to position zero, keep injecting, and then I'm coming out of the eye, and now I'm pretty happy. So now I'm like, well, at least the patient's not going to need a YAG capsulotomy, right? You got to think of something good. Well, okay. More viscoelastic going in. I'm kind of just like buying time here. Like, I don't know what to do now. Now, patient is, capsule's open. Do I need a vitrectomy here? Yes, because the posterior capsule's open. Yes, because vitreous already prolapsed. No, just use Wexel and scissors. No, the anterior hyaloid face intact.
The anterior hyaloid face looked intact.
Well, how do you know?
Doing that. You don't know until you check the wound for vitreous, so I'd use a Wexel and check the incision for vitreous, but I wouldn't go in and touch anything unless I knew vitreous was coming forward.
Got it. And how about you, DP?
Yeah, you did a fantastic job of keeping the eye pressurized. Vitreous did not come forward, you did not let it, and so you don't need an anterior vitrectomy.
But how do I know? Like, I can't put triamcinolone in now, right?
Correct.
Because I have all the viscoelastic, it won't work.
Correct. Yeah, I would just put the lens in.
And then what if the pupil's peaked? Then deal with it later.
Then do the vitrectomy after
Yeah.
you have the lens in.
Okay. And what are you thinking for lens choices here? Single piece in the sulcus?
No.
Trying to see if they're awake.
Yeah.
Give us a heart attack.
I would put a 3-piece in. You have a beautiful, in the sulcus, and you have a beautiful anterior capsulorhexis, and then optic capture.
Yep.
And that way you don't even have to worry about changing your IOL power choice because you're basically in the same plane you would have been if you went into the bag.
Although you may have to change if you're doing
Because,
like from
yeah,
a single piece to a three piece, they may have a different A
just
console. But
depends.
you're right, the lens position is the same if you've opted captured it there.
Now, if you were, I don't have time, so I can't say what I want to say, but if this was a toric or something like that, I wouldn't put a multifocal in, but you could capture it in those flaps too. Sometimes they're pretty stable, and you could put a three-piece in the bag with the haptics in those flaps.
That's a great point. So here I'm going to actually put in more viscoelastic. I'm just kind of buying time while they open the lens for me. I'm going to take your advice. I think this patient doesn't need an anterior vitrectomy. I think the hyaloid face intact. I'm a little worried that I keep injecting more and more viscoelastic in the eye, but I suppose it'll be okay. So we talked about the lens choices. I'm going to follow your lead too. Three-piece lens, haptics in the sulcus, and the optic captured behind the rectus. And I think that's going to be a really nice approach because it'll give a good barrier effect. It's going to be super stable the rest of the patient's life. Now, you were talking about B, that you could actually do if it was a toric type lens or trifocal EDOF lens. Tell me about that.
You could put your haptics, you really have to be, I would discharge the lens into the anterior segment and then use a second instrument to put the haptics and lay them in those areas of split. So not where the split is, but into the pockets that are
90
still
degrees
there.
away from where the split is.
Where the split is, and you can have it sit there. But your best choice here, if it's not a premium lens, is to put, I think, a three-piece in the sulcus with an optic capture. It's the easiest choice to use, and then you can deal with an LRI if you've got something to do, or you can do something later on if you couldn't put a toric in. Just
So
depends.
you agree, DP?
Yeah, I would just put a three-piece in the sulcus and optic capture.
Yeah, I think that's
because
the easiest choice
It's
here.
like, you just, I don't know if you know how stable those flops will be. It's a great technique, but your posterior capsule rupture was huge.
Right. So in this case, it was going to be for a T3 toric lens, about a diopter still. So you're right. I'm going to follow your advice. Three-piece lens. I'll do a little LRI at the end here, and we'll have a real nice result. So I'll show you what I'm doing here. And boom, there we go. So I'll slightly enlarge the incision too. So I've realized that I don't need to struggle to get that three-piece lens in.
No.
And if I try shove the three-piece lens in through the smaller incision, what ends up happening is I get vitreous prolapse.
That's it.
So I've learned, make a big incision, it's okay. Here comes the lens, leading haptic going in. Plenty of seats way up in the front, guys, if you want to come sit up here. And so there's the lens. Now get it dialed in, make sure those haptics go in the sulcus, and then there's the optic capture.
Beautiful.
And yeah, I'm gonna be pretty happy here. So now, looks pretty good. Here, another thing is I'll try seal up the incision first before taking out the viscoelastic, so that as I take out the viscoelastic and I come out of the eye with the IA probe, I don't flatten the AC again. I'm just weary of flattening out that AC and letting vitreous come around. And then here, for settings on the IA, I'll just use lower settings, lower flow, a little bit less vacuum, just kind of take my time on this. It always looks pretty if I speed up the video, but in reality, this is takes a little bit longer. And so again, there's a really nice optic capture. You can see it behind the rexus. Good thing we had a nice rexus here. And this patient had just a beautiful outcome. The post-op day one was absolutely happy. Cornea was clear. Refractive target was spot on. Here's some triamcinolone just to make sure there's nothing that rhymes with yttrious in the front. And that looks good. And also help it'll quell inflammation. And at the end here, I'm going to do against the rule LRI. So what do you tell this patient post-op? A, you have really bad anatomy and ugly protoplasm. B, why did you move so much? Or C, the capsule is so weak, so we use an alternate lens and it should not have a negative effect on your vision. Or D, the good news is you don't need that capsulotomy. So what do you tell them here? No, it's actually a serious question. What do you tell the patient? C, we tell them C too, but I also tell them a little bit of A. Right? I mean, you think about it, you have a little bit ugly protein. It wasn't, what did I do wrong?
But Uday, why do you think you rupture the capsule here?
Because the patient has bad, ugly protoplasm.
From the posterior capsule, you think it had a focal weakness? Did the patient have previous injections or anything?
Nope. No prior injections, nothing else.
I think here, perfect was the enemy of good.
Yeah.
And you could have used a little bit of viscoelastic to peel that little piece off. So sometimes, there's an old saying don't gild the lily. Sometimes you just got to leave it. And if you put them on a steroid, they would have been okay with that little fiber there.
Any
Or
audience
then
Q&A,
you-
don't be shy. Jump up to the mic. You got 51 seconds.
You could have then built a yak capsulotomy. Now you can't.
No, but I feel like we polish the posterior capsule pretty aggressively with that polymer tip. I do that all the time. And
Was
so,
that too aggressive?
But you
No,
turned it
you
over.
weren't.
That was the problem.
Did you have vacuum?
Probably.
Oh, so I just squeegee with the polymer tip as opposed to, trying to grab. But it did
But you
look
could
like
do a
you
little
grabbed.
tiny bit of vacuum.
I mean, if your tip is up, I typically don't, vacuum the capsule. I just, if there's things lifting up, then I'll vacuum that. But
The other point that I think is an elephant in the room is you left a ton of dispersive viscoelastic
Yes.
behind the lens. So you have to put these patients on some IOP lowering drug
Right.
afterwards, or even
Diamox.
Diamox
Yeah.
for a while.
Totally agree with you. All right, let's go to the next case. So we'll have a Q&A for every one of these for the audience, so if you feel like it, jump in. All right, case 2, posterior polar cataract. We lost our sound effects. It's supposed to go like, da-da-da, cataract.
we can just do that.
We'll do it.
Da-da-da. Okay.
So here's posterior polar. So already this was in my schedule, it was booked as PSC. And I'm like, wait a minute, that's not PSC. So how do you know posterior polar versus PSC?
When you look at the slit lamp, you can see.
Oh, yeah, I know.
Do you examine your patients
I was just gonna
preoperatively,
say
doctor?
Yes, kinda.
Okay, just checking.
Of course I do. So here, getting the rexes done. Now here, I really want to make sure I have a beautiful rexus because, right, studies from Osher and Vasavita show that it's a much higher rate of PC rupture in these cases. So what's most risky here? And there's the Osher's reference. Rexus, hydrodissection, hydrodilation, nuclear fractus. What's the risk here?
Dissection.
B, hydrodissection. You should never do a hydrodissection.
How about just a little bit till the wave goes right up to the opacity? Can you do that too?
No.
No?
I do a mild visco dissection up until I do a visco. I don't even bring a BSS cannula into these eyes. I do a visco delineation and I do a visco dissection, only flowering to the part of where the posterior polar cataract is.
Oh, I like that word, flowering. So like in all the quadrants sort of comes.
See, I'm not just a pretty face.
So which viscoelastic are you using with this? A dispersive agent?
I'll use a dispersive.
Like HPMC, hydroxyperoxy methacellulose, or you use like a viscoat? Or
Viscoat. I use viscoat for it.
And you do the same thing then?
And if I can't even delineate the nucleus up and out and sandwich the epi down while I'm removing the nucleus, it depends. So I try to take posterior polars in early as possible because if the nucleus is dense, and I've had it where you've had a totally white cataract that walks in and you go and you hydrodissect and it drops, right? And that's an undiagnosed posterior polar because you just never saw them at a posterior polar state. But so earlier is better on these cases.
I just delineate and not dissect, get the nucleus out, and then do the visco dissection of the cortex, just like Rosa said.
I think that's a great way of doing it. So
I flower it, even the cortex, I'll flower it and I take that piece off last.
I like that. So here's I'm doing the delineation. I'm trying to stay within that rexus because I just don't want it to go hydrodelineate. I want the delineation only. I want that golden ring. And then like you said, hopefully the patient's on the younger side, which it looks like from the eyelashes, I want to get this endonucleus up out of the bag there. Well, there's the TV commercial.
You can tell the age based on the eyelashes.
Can't you look? It looks like a younger patient.
It could be on a latanoprost-like drug.
Yeah, I guess.
They could be fake.
So here I'm just dialing up, getting that endonucleus, kind of digging it out of the bag a little bit. I don't mind leaving the epinucleus and the cortex back in the bag, but I want that endonucleus kind of up and out. And so now I'll go inside here and emulsify this thing. I'm also weary of doing like too much nuclear fractus in the bag because I don't want to put stress like I'm trying to split two halves. Let's say if you're doing a divide and conquer, you're trying to split two halves. So here the endonucleus comes out. You can look way in the back in the posterior. You can see there's still the opacity, so I'm happy there. Any other pearls for this part?
I mean, if you're concerned at all, you can, instead of using a second instrument, you can, well, so first of all, so stop there. Oh, you can't. But I wouldn't have come out of the eye with the phaco. I would have injected viscoelastic at that point in time.
In fact, I may just do that. I'll show you. So here, use the coaxilated generative cortex, use bimanual cortex, viscodissection, what you talked about.
Yeah.
Now, could you perform hydrodissection?
No.
Still no.
No, but I also I don't want that. So remember, even when you've got a posterior capsule rent, if you decompress the anterior chamber, that rent's going to extend, right?
Right.
So even in these cases, if now you come out with phaco and that capsule comes up, it may break in its area of weakness. So you never want to let the anterior segment
That is
decompress.
such an important point, and I've learned that the hard way. So again, to reiterate her point, don't let the capsule come up. So don't flatten out the AC, because that posterior polar opacity, just allowing the capsule to float up is enough to rip it wide open.
Yeah.
So that's a really great point here. What about for the nuclear fractures technique? Any technique's fine? You don't mind doing chop in the bag? Or you still want to get it out of the bag?
I don't mind doing chop in the bag. You can do it if you do a gentle chop. You don't want to push down. You don't want to do that. But if you can get even a heminucleus out, you could even go back and do a sculpt and then do a stop and chop if you want to. Because really, as long as you keep the bag full, the chance of that breaking is a lot lower, okay? So keeping the tension on the bag is important to be full, not a capsular tension ring, but just to be full. So
Like don't let the AC collapse, basically.
that's the most important.
So yeah, I'm going to take your advice here. Look, see, I was listening. I listened last time. So now we'll inject the viscoelastic, not let the AC collapse. And now I'm going to do the visco dissection you talked about, the flowering technique.
I know,
Learned something new today.
we got to write it up.
The flower, it makes sense though. But yeah, I'm just going in all different quadrants with a dispersive viscoelastic, not too much pressure, and just kind of digging it up, and I think that should be pretty good. And now, are you going to put the IA probe back in here now, or are you going to put the phaco probe?
IA.
Yeah, me too. So, and I just, even if it gets stuck, I can just use the spatula or something else, second instrument, to kind of push it down the port. But now I'll take the rest of this, and I'm pretty happy here. Now, for lens choices, let's say the bag looks pretty much intact. You can put any lens you want?
Yep.
I would do a one piece.
A one
A very
piece?
gentle.
Is there a reason why I like the one piece?
Because it's gentle. As
Oh, so it opens up. So
yeah, not like a three piece that goes boink into the bag.
So deliver it basically closed
Deliver.
up into the bag and then let it slowly open in the
Yeah.
bag. All right, very smart, for sure.
You can always inject whatever lens you want, again, into the AC and then put it in slowly into the bag as well, if you're concerned.
All right, so here comes a little last bit of it. I'm looking carefully. I'm always looking back there like, oh boy, now what? Now what? What did I do wrong? Anything?
Perfect.
Oh,
You did
got
a
lucky.
great job.
Woo-hoo. Better to be lucky
beautiful.
than good, right?
So do not polish this capsule, though.
Yeah.
You sure? But there's a little smudge right there.
Do not polish this
Oh,
capsule.
you did. Okay, wait.
Do your polish capsule. A, use very low vacuum. B, mechanical capsule polish instrument. C, gentle hydro polish. Or D, you'd be crazy to touch the capsule.
D.
Cuckoo bananas. To
Yeah,
touch the
I mean, we
capsule.
already saw the first case, right? But especially here, because we know that posterior capsule is going to be thinner than a typical capsule, right, in these posterior polar cataracts. So here, especially, you want to inject viscoelastic with your left hand and decrease the irrigation, so fill up the bag before you come out with the IA tip.
Fantastic. I love the advice there. But yes, you don't want tons of capsule. What about anterior capsule rim polishing? You fill the bag with viscoelastic. You can use the mechanical polishers on the undersurface of the anterior rim, not the
fine.
posterior capsule. Is that okay?
Fine, sure.
You let me get away with that one?
Knock yourself out.
If you're standing in the back, there are seats up front here. We're going to have every seat full. Yes. So I agree with you on this one. I'm also going to put that single piece acrylic lens in the bag. And to me, that's going to be the easiest choice. And like you said, I want to put it in very gently so that as I deliver it, it goes in the bag all folded up and then slowly opens up. And then I don't want to manipulate it too much. I don't want to rotate it around. Hopefully, we'll see. I don't think it's a toric lens. Hopefully not a toric lens. If it is, I want to get that toric lens pretty closely lined up prior to the arms fully opening up. And we've run that. Will make life a lot easier here. So here we go. Let's see what's happening next. Hope you like the format. It's an easy way of staying absolutely on time. So here you go. More viscoelastic like you taught me. So here comes a cohesive agent. Not going to overfill, just enough. And not come out of the eye. And then now, for the lens, we're going to put that single piece lens in here. And I'm not going to polish. You can see the undersurface, the anterior rim. Arguably, you could say, well, you could go in there and polish it a little bit. But I don't want to do that. So again, we're going to do single piece acrylic lens in the bag. Would you ever put a CTR in a case with a posterior polar? No. What if there's a posterior polar, but you had like zonular loss too? Would you put a CTR, or you think that's too much force?
You could put a CTR in, but make sure you guide it. Like you've got to have a Sinsky or something in your second hand. Hold on to the little hole of the initial CTR and guide it in there slowly. Don't let it snap into the bag.
So you're doing like a Sinsky in the left hand, injector in the right, but you do it differently. You like only forceps.
I just inject, but keeping the CTR all the way over to the left, so then as it's coming out, it has an extended range, so it's very soft. You know, it's not very
So you're going more
tense.
tangential,
Yes,
not
exactly.
not
That's
radial.
Josh Teichman taught me that. Exactly.
And that makes a lot. In fact, a good thing you talked about CTRs because we got a case coming up where I got a quiz for you.
And just at this point, I'd like to make the difference between, because I do a lot of cases that are post-injection by fellows or residents, and so sometimes you can see that the posterior capsule has been compromised. The difference there is that if you wait a couple of months, that posterior capsule will scar, so it's not as thin inherently as a posterior polar. So it's a little bit of a different animal. Even though I do the same sort of thing, I'm not so worried at the end that it's going to rupture, because if there is a scar, I'm going to have to YAG it after, because it's not as thin as this.
Okay, so yeah, I'm using your advice here. Boom, single piece of acrylic lens in the bag. Luckily, it's non-toric. I'll just get it where I want it. It opens up pretty atraumatically, and they're high power lens too, 27. So small eye, hyperopic eye. Seal up the incision here at the end too, while the eye's still full of viscoelastic, because like you said, I don't want to cause any flattening of that anterior chamber. So take out our viscoelastic here, we've sealed that incision, and I'll even just use BSS in the other hand, just to make sure I don't flatten out the eye too much. So get that nicely hydrated. Yeah.
Another thing you can do is put an air bubble
Oh,
in
nice.
the AC so that you don't flatten the AC. Because when you use BSS, oftentimes it still shallows.
Right.
But if you put an air bubble, it will not shallow.
I've never even thought of that. Yeah, an air bulb at the end of a routine cataract case is common in other countries. In the US, I don't see it too often, but that's a nice technique that we can use. Any audience Q&A, if you do, step up to the mic. We have Q&A built in here because of feedback from last year where they said they wanted Q&A. Yeah, jump up there. You got 31 seconds.
Talk fast.
For some cases like this, sometimes I make a second paracentesis just in case
Yep.
you need anterior vitrectomy or bimanual eye. Anything else on that?
I love the idea.
Great.
A second pair, no harm, plus then you can do a bimanual IA. I like that.
Yep.
We had another
How
comment?
often do you see the fishtail sign that we all learned about? I never see it with these posterior polars. And they're posterior polars.
Right. Panel, I don't...
No, I haven't seen it.
Yeah.
Well, that's the difference. Now we learn by videos, not by reading stuff in books. This is totally different. Honestly, it's a brave new world. Let's go to the next case. Ta-da!
Cataract Coach.
All right, tennis ball smack in the eye. Here's a resident case. Look, what do you think's happening here? What's happening right there?
Zonular laxity
Oh
or
my gosh.
dehiscence. The lens is totally decentered.
So we got a resident case here. Resident says, "Oh yeah, they marked it for a toric lens." Good to have high hopes. So here we go. Some viscoelastic going inside. Here's an incision. Looks pretty reasonable. What do you just see? Is it A, quadrilateral loss, B, shallowing the AC, C seems like a routine case? Nothing, because I was playing on my phone. No, I think I'm doing a good job. No one's on their phone. There are
so
seats
funny.
up front. If anyone in the back doesn't want to stand, there's seats up here.
So
So, obviously, big quadrilateral loss. So tennis ball injury to the eye. So what are you thinking immediately when you see that much line loss? How many clock hours do you think that was?
That was about 4 clock hours at least.
Yeah, it's always a
3 to
little
4.
more than you see, right?
Yeah.
It's always a little more than you see. And do you think I already have vitreous prolapse?
No, it didn't look like it. Although your pupil, that's the one thing I always look for when your pupil's so hyperdilated, is that there could be, just like when a pupil's not dilated enough, if it's hyperdilated, there could be zonular.
This patient actually has traumatic mydriasis too. So the pupil's been like that for a year.
Okay.
So this is the nice part is you don't have to put in any eye drops to dilate them. They're ready to go. You can have whatever you want. All right, so here's what happens. So yeah, obviously, the rexus looks pretty normal. Why? How can I get a normal rexus if it's that much zonular loss?
Because it's focal.
Right. So there you go. Here's some hydrodissection,
Nice.
some delineation. Get the endo nugget out of the bag. That's me helping the resident. Now the resident has to just put the phaco probe in and aspirate it down. So going in here with the phaco probe, and we'll start to aspirate it. And so the mucus removal in this case is obviously not the hard part. So we're definitely going to put a CTR here. Do I need more than the CTR? Do I need like a Sione ring or an almond segment or something? How do I know?
I usually don't do more than sew anything in unless it's more than probably about 6-7 clock hours. So this, I'd wait and see, but I mean, you could put an almond segment in or you could put a CTR in. See how it's, like I would have put my CTR in already, but that's just me. Fill up that bag, fill it up.
So yeah, now you can see it keeps coming forward here. So here we learned from last year's cases where you told me, admonished me. So now I'm using, or had the residents using a bimanual IA. This is that transformer handpiece, and so pretty easy to remove, full 360, and it looks pretty reasonable.
So here's that bilateral paracentesis you talked about.
Yes,
That's really
good point.
important.
We had the double para. Absolutely. So now we probably want to put viscoelastin before coming out of the eye, but let's put in a little bit of this.
Okay.
And let's see, what do you think? Okay? A little bit.
It's got to come off the foot pedal.
There's a little bit right there, that little tag.
Don't touch it. Oh, Jesus.
Just, it didn't happen. Push it back, don't worry about it. Now, what do you do here? Okay, A, endovitrectomy for that small prolapse of vitreous. B, don't worry about it. Just insert the lens of the bag. C, insert the CTR now. D, remove the bag and plan for Yamane. What do you want to do here?
Jesus Christ.
Well, sometimes the senior residents want to get that Yamane done, so.
Oh my gosh.
What do you do here? Someone, tell me.
I would put the CTR in. I would go ahead and put
No
the CTR.
vitrectomy yet?
Not yet. But the
No.
CTR in. This is a young patient. Did you see by the eyelashes?
Yes,
Very
yeah.
very young patient. I could tell.
You guys are tough.
Yeah. So the vitreous is just going to pull right back. You're going to be fine.
I agree.
Okay, so we're going to put the CTR in, and again, you're going to use an
Because
injector?
if you do a vitrectomy now,
Yeah.
you may start watching that whole bag unfold on you. More vitreous comes forward in
Yeah.
the bag, and then the Yamani comes in really, really well. But so put in your CTR, see what happens, restain, and see if they're
There
still
you
in,
go.
do a very localized vitrectomy in that area. Or do nothing because he doesn't have a pupil, so you're not going to peek it anyway. So
You'll never know.
Well, you know, the important thing here is that you're saying is that the capsule, especially when it's loose like this, can be sucked down the vitrector in a second.
In a second, yes.
it just folds
Yes,
in.
yes.
It, like all the other zonules decide to give up when you start doing a vitrectomy.
So, okay, we're going to do the CTR. We've learned our lesson here. So here comes the CTR. We'll fill the bag up with the viscoelastic. Here's the CTR. Just, the resident here is just going to forcep it nice and easy. Goes all the way around.
The Dhaliwal technique.
Yeah,
No,
it works great.
I use an injector, but it looks great. I'll take
And
that.
here's the lens. We're going to do 3-piece lens, haptic sulcus optic capture. What do you think about that, or would you put the whole thing in the bag?
I would put the whole thing in the bag. He is too.
You could do either one.
I would put it in the bag.
But when you put a 3-piece in the bag in an area, when you have a zonular loss or defect, you want the haptics in that same area.
So if it's in the bag, the haptic pushes out as an extra strut to give
Right,
support. If it's
right.
like this as a sulcus, I want it 90 degrees away.
Exactly.
And now optic capture it. And
Yeah.
there's still that little bit of vitreous with the triamcinolone. Just leave that alone? Or should we get it now? There's that little tiny thing right there. Like, could you push it back?
Just push it back. There you go.
If
It's gone.
If you don't see it, you're good. You're safe. Okay, we followed your advice. Now, pulling the iris, we're going to do a pupiloplasty here. We're going to grab, oh, there's that little more of the vitreous.
I mean, you could do a localized vitrectomy.
So do you use an anterior vitrector or just use some like micro scissors and cut it like there and call it a day?
I would probably just do this because it's way more controlled.
Yeah, I just do that. That's it.
The
Done.
problem with putting in a vitrector right now would be that you again risk what we said before, just pulling more and more vitreous forward.
Right.
So if you can do it and you don't have any peaking of your pupil and you don't see any left, just leave it.
So what are you going to do for the chronic mydriasis? It's not that bad. Just give them sunglasses. Come back another day, reasonable. Refer out to another surgeon, or are you going to do a pupiloplasty?
If you have the skill set to do a pupiloplasty, these patients are grateful that you fixed them for so many different reasons, cosmetically and obviously from the photophobia standpoint. So if you can do it, then it's fantastic. And now there's so many easy ways to do a pupiloplasty.
So would you do like a cerclage per string? Or are you going to do the 4th throw pupiloplasty like Agarwal's taught us? What are you going to do?
You can do either one, right? So I've done both. I mean, the Ogawa cerclage method is really elegant and those pupils look beautiful afterwards, but it's a little bit more effort. The 4th throw pupiloplasty by Amar Agarwal's technique is super easy. So you have to be great to have one of those skill sets in your toolbox so you can pull it out when you need it.
And now you teach residents. This is a senior resident, let's say in December, so 150 Ks under the belt. You're going to try cerclage, just do the 4th row.
I'd probably do a 4th row. Time's wasted, right? You got to get the next cases done.
As someone taught me when I was a resident, you got to make it to lunch on time. So okay, I think we're gonna do the same thing. We're gonna do 4-throw pupiloplasty, and I think it's gonna be a really nice approach here for this patient. So not difficult to do. Again, this is a 10-0 polypropylene on that long CIF4 needle. And so a couple of pearls here is to kind of grab that IF tissue to give it some support. Don't go too close to the pupil margin. On the other end here, I'm just kind of grabbing that tissue with the hollow bore needle and then kind of giving a guide to pass it through. And you can see I'm
What
kind of
suture are you using?
10-0 polypropylene CIF4 needle. And so there it is, the blue stuff. It's hard to see on the videos, but we'll pull that through. And there's that loop that we can pull out the side here. The whole video spent, this case was about an hour, and that's with me scrubbed in helping the resident. So not a fast case, so only put this at the end of the day. There's the 4th row, 1, 2, 3, 4 throws. And you can see the resident's doing the suturing. I'm just there helping hold the one end so it doesn't fall in the eye. And now we can tighten that up, and you'll see it looks pretty reasonable already.
Nice.
And so we'll put a few more. What's your ideal pupil size here that you want to make? For a routine case here, the cornea is otherwise normal. What do you want to do? Just
About 4.5, 4.
four-ish?
Yeah.
I think 4 is like the sweet spot, because then you still have a pretty good view of the posterior segment. Obviously, you're not going to be able to dilate the eye anymore. And then it looks pretty reasonable from conversation distance. Obviously, the lighter the color of the iris, the more obvious that any kind of defect will be. So you can hear now another suture to close that defect up. And it'll start to look pretty good.
Nice.
And now, would you put another one down there inferiorly just to kind of smooth it out, or is this enough?
Yeah, do it. You're doing such a good job. Keep on going. It'll look really nice when you're done.
And so there we go, tightening that up. So this is an easy technique, and that's about the goal. The pupil 3.5, maybe 4 millimeters, somewhere in that range. And this patient's going to have just a really nice outcome and have a nice, stable refractive result. And then you can see the main incision is sutured up. Certainly for a resident case, I don't need to have any more vitreous coming forward. So let's make sure that's sutured up and sealed, and everything looks good here.
Looks great.
All right, so these were the easy
Beautiful
cases.
case.
The hard cases are coming up. So yeah, routine case there. Anything from the audience for this Q&A? You got a minute, just jump up to the mic or yell real loudly. And we still have plenty of seats in the front. You don't have to stand.
How many people do pupiloplasty?
Oh yeah, for sure. Easy.
Yeah, super easy. Well within the wheelhouse.
I think the most important thing in doing it is just keeping the spaghetti strings straight.
Yeah.
And make sure your drapes are good. The worst thing possible is you're trying to do this pupil suturing. Come on over. And pupil suturing, and then you've got like eyelashes in the way.
Yeah.
The worst.
Especially the young eyelashes.
Oh.
They are ridiculous. So yeah.
For sure. For sure. All right, we have a few more fun cases coming up here. I want to remind you, too, I got a beautiful podcast. These guys have already been on the podcast as guests. You can learn a lot. It's every Sunday, everywhere you find podcasts. Apple, Amazon, Spotify, Google, YouTube, etc. And you can tell me who is the better podcast. All right, brunescent cataract. Dun-dun-dun. All right, here you go. This is a pretty brunescent cataract. This is a Beverly Hills patient. So this is trypan. We'll stain that. And what is your approach for these? You got a lot of these out in Pittsburgh. Lots of brunescent cataracts.
Oh yeah. So one pearl for putting trypan in is I decompress, so let some aqueous out before you put the trypan, so you get a nice intense stain.
There you go. Another way for an intense stain is I just leave the dye on there longer.
But if you leave it on too long, the capsule gets very fragile.
Gets more. That's a good point.
So you have to be careful.
The dye makes it brittle.
Yeah,
You're right.
There's
I do
sweet
it
spot.
totally different.
How do you do it?
I use a little layer of viscoelastic to coat the cornea, and then I paint the capsule
Paint the capsule.
so that you don't stain the corneal endothelial cells.
So I do that in cases where I'm worried about the endothelium, like in Fuchs cases, or zonular issues.
Right, because
the
you don't
trypan
want,
goes
if you
back.
ever get trypan going back,
You
you
lose
have
your-
no red reflex.
Yeah, you lose your red reflex.
So how are you going to divide up this very brunescent cataract? Divide and conquer, stop and chop, some variant of chop, femto, lens loop, lens snare, pull out of the bag, crack the posterior plate.
I love Stop and Chop. That's my go-to case.
But even when you have that posterior plate that doesn't want to split?
So then you can use a lens loop or a lens snare. Those work great for that. There's so many different techniques.
So what would you do in this case? Stop and chop?
Yeah, I would start with the Stop and Chop because you don't really know until you know.
Right.
So I actually described a technique, and it's in the JCRS. It's called pocket chop, and I do almost like a half pocket or a half groove. And then I have no financial interest in it, but I have a Braga-Mele chopper that is a tomahawk sharp chopper for these. I only keep it in the eye for as long as I have to because it is daunting sometimes, even in my hands. And then I chop this, and the key is you cut it, you have a good grip, you pull up and you chop, and you make sure you do not move until you get that posterior plate split. If the posterior plate splits and you get flower pieces, I love flowers, right? You get flower pieces, you can do a reverse karate chop. And when you have that piece, you bring your chopper behind it and then karate chop towards you and split it.
Well, you're not going to like me because I'm not going to follow any of your advice. Sorry.
Are you bringing it into the
Well, let's see what I'm going to do here. I got a nice juicy rexus, a big 5.5 plus rexus.
Which is what you have to do for these kids.
Yes.
Yes, no baby rexus.
So the denser the lens, the wider the grooves. That's what I always say.
Okay.
If you're going to do a, divide and conquer or a stop and chop.
So how about this technique? Oh my God, you're crazy.
Ay. Oh.
If you
That's
were my
painful.
resident, my
That's
coronary
so painful.
arteries would have died already.
God.
I don't know how you did it.
Set them up for the DMEC now. Just schedule it. Just do it. This is ridiculous.
But look, I'll be able to get that posterior plate now. Look.
Yeah.
Look, I don't even have to do cardio today because my heart rate is up. Just watching you do surgery.
Okay, I'm gonna buzz in here. I'm gonna look at that. Look, I can bench 225 and still have that much effort to crack this thing. God, tell me divide and conquer, stop and chop would have worked there. It's not gonna work.
It would
You didn't
work.
try it. It'll work. We do this all the time. That.
Did you recoat the cornea with viscoelastic?
No.
Next year I'm doing different panelists.
Yeah. You want to phaco in the bag as much as possible for these really dense cataracts. It's not how much energy you use, it's where you use it in the eye.
I got bevel down.
So, the more you're in the bag, that's better in terms of the effect on the corneal endothelium.
Boom, just like that. Now it's time to polish the capsule. All right, so get it all cleaned up here. This time I will not polish the capsule. I will just, I want to get that floater there. So we'll get the lens in, and you know one of my tricks here now is I'll put some triamcinolone in the AC, some preservative-free triamcinolone. We just make this ourselves with the brand name Kenalog. So if you want to hit the nucleus hole, what are you going to do? A traditional extra cap? You're just going to enlarge the corneal phaco incision, push into the vitreous, refer to the VR colleague, or you're going to learn to perform M6 because you watch CataractCoach.com.
Dum dum.
What are you going to do? Do you guys still do manual ECCE? Or have you switched over to M6?
Switch over to M6. Absolutely. Yeah. It's such an elegant technique. This is another thing that we all should have in our toolbox for cases that are more dense than this, that you really cannot phaco through. Right. It's an elegant technique, and it brings back all the, the key there is just doing a beautiful scleral tunnel and making sure that that's a really wide tunnel. It works beautifully.
I remember back when I was a resident, they taught me ECCE with these corneoscleral scissors to the left and to the right. That was barbaric. Absolutely. No, so ECCE, I think, is the old style was terrible compared to M6. M6 really is a really beautiful technique. Yeah. It is not difficult to learn. And I've got a few simple pearls to make it easy for you. But I think it's important. In the US, around the world, surgeons all perform M6 all the time. But in the US, I think we really don't do it nearly enough, and a lot of training programs for residents don't teach it at all. So I think for me, it's important to teach it, so I'll show you how I do it. Even in Beverly Hills, a couple times a year, I'll use this technique. It just makes life so much easier, so much less stress, and a better outcome. So here are my 4 simple pearls, and I do got some cheat codes here, which I'll share with you. And the first thing is what you said, was make a great incision.
Yeah.
So the incision, so I'm sitting superiorly here, do a peritomy. The incision has to be shelved.
Yeah.
And that's the key here. So we're not going to go right up at the limbus here. You want to go a little bit further back. And this incision we're going to make with a crescent blade, about half scleral depth. Now you can do a straight line here. Some people do a frown. But the key is that it's going to be trapezoidal, so wider on the inside than the outside. And then look at the tunnel length. It's a lot longer tunnel length than you imagine. You can see this is a pretty brunescent cataract, pretty dense. This patient also happens to have a lot of sill, 2 diopter sill with the rule. So I'm thinking perfect. So we'll get this done, and there's the incision. Again, it's half scleral depth, and I haven't entered the AC yet. So now this is still within the cornea, And you can see how it's that trapezoidal shape, wider on the inside than on the outside. When in doubt, make it a little bit wider. And I'll get the Trypan blue dye out. I also make an opposite paracentesis, and I'll show you why and how I use that. So here's the viscoelastic going in. At this point now, I can make our rhexis, make the end of the eye here. So end of that scleral tunnel, wiggle the blade back and forth so I'm not catching any lip of it. And now through the regular small incision, make a generous rhexis. You had an important pearl, which is the denser the nucleus, the wider the rhexis.
Yep.
And I think that's a very important thing. So I have forceps there that are marked off at 2.5 and 5 millimeters. And what looks like a monstrously huge rhexis is going to be just about perfect. So it looks huge, but it's actually going to be great, and it's going to overlap the optic, a 6 millimeter optic.
Yeah.
And so here, a little bit of hydro dissection. You don't really see the fluid waves because the nucleus is so dense. And then we'll get that up and really get it up out of the bag and get it above the iris. Make your life easy. So make sure that lens is dialed up above the iris 360. And then recoating with viscoelastic.
Thank you.
Thanks.
Well, Martin's right here. He'll teach me how to do a DMAX. So more dispersive that are above it and beneath it. And then again, my cheat code here is once we open up the incision, make sure you open it sufficiently wide. You don't want to struggle with this. That's one of the things that I did at the beginning was struggling. Now put more viscoelastic, and now I'll just use the spatula here to push it out.
That's great.
Don't lift the lens nucleus up towards the endothelium, ever. Because then you'll scrape the endothelium. So instead here, I'll just push it out. I'm staying, all force vectors are parallel to the iris plane. So I'll just push it out of the eye here, push, 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 like delivering a big baby. And there it is.
Beauty.
That would have been a lot of phaco powder. And now another thing is I like to suture the incision. When it's taught in other countries, M6 is done sutureless, believe it or not, because the incisions are so well constructed. So I'm not as much of an expert at M6 because I don't do 1,000 of them a year. I just do a few. And so here we'll suture up the incision, and I'll just put in 2 10-0 nylons interrupted. And I think that's going to give me a really nice apposition of the tissues. Plus, then I can still go inside here with my coaxial stuff.
Yep.
And aspirate out the cortex. I can also put the lens in between these two sutures because that's at least 3 millimeters between the two. And I think it's just a nice way of doing it. So I do like to still put sutures in these. You can do M6 superior as well as temporally, but in this case, I think I like to do superior because the patient has 2 diopters with the rule sill. So here, generally for M6, people like to do the bimanual IA only so you don't get that iris prolapse you see right there. But that comes, the cortex comes out pretty easily, and then you'll see we'll get the lens in, and we'll call it a day. So those are my pearls for M6. You got any pearls to let us know?
I like an irrigating vectis to remove the nucleus.
Oh, nice.
So you don't have to push it out. Really, you're just depressing the wound and
floating it out.
And it'll just come out. So you depress the main wound. That's the key. So you never lift up and use the endothelium as a second instrument. You just depress the wound and it'll just kind of irrigate
Instead
out.
of a spatula to push it out, which I thought was great. So if you don't have an irrigating vectis, you can't get one. You can also use your dispersive viscoelastic through that other one and kind of push it out with the dispersive viscoelastic. The other thing is if you don't want to put nylon, you can put Vicryl sutures and then they'll dissolve after a while. And then if you get a good bleb, you can bill for a trab. So it's all good.
How many people are doing M6? Awesome. So if you didn't raise your hand, you better learn it. It's not that hard, I promise. Any other questions from the audience? Yes?
What do you do if you have a Flomax patient, same dense cataract, pupil doesn't dilate, you have a huge
Right, so if you have a Flomax case, you want to do M6, you can also do it, obviously. I think hooks is probably your easiest option there to really expose it. But what I do instead is you see my videos, I rarely use hooks or a ring. I'll just get a big rhexis and then prolapse it up and get it above the iris. Da-da-da, CataractCoach.com, next case.
Da-da-da. But how do you get a big rhexis if you have a small pupil?
Jedi Mind Force, you can do it underneath it.
Oh.
I'll show you.
You should show us a video.
It's coming. It's coming up. So here you go. Here's a case of some iris prolapse. So watch what happens here. So some hydrodissection, fluid going in.
Oh, you can
this
see
is coming out.
There it comes.
What's going to happen to that iris?
I don't blot the lens down. Oh, God.
So what's your next move? Push the iris back, more viscoelastic, release trap BSS, do pars plana tap. What are you going to do here, panel?
Release your trap BSS.
By doing what you were saying, blot?
The lens down. Let
Push
the
the-
fluid come up and over. because you've got too much posterior pressure. I mean, you've talked about this. There's too much posterior pressure, and that's what's pushing the iris.
So what did I do wrong? Too much BSS?
Yep. Yes, too much fluid.
And also you want to make your incision a little bit more anterior to get less prolapse.
Would you start more in the clear cornea then?
Yeah, a little bit, just in these cases.
Okay, and so you wouldn't do it, so you want no more viscoelastic. What about that? So normally the resident technique is like, well, put more viscoelastic and push the iris back in.
No, you want to decrease the pressure gradient.
So solve the gradient.
Yeah, and then the iris will go back. Iris, like you taught us, Uday, the iris always follows the pressure gradient.
Right, so in this case I put way too much BSS to do the hydrodissection. As a result, I highly pressurized behind the iris, and obviously in front of the iris the pressure is very low, and so the iris prolapsed out of the eye. And probably the first hint was you saw the nucleus come up,
Yeah.
and then you saw viscoelastic being burped out of the incision. So that's already there. I probably should have stopped and said, wait a minute, let me not continue on this path. But there is an easy way, right? So like you said, we'll just blot the lens, release that trapped BSS, and I can solve this with literally a second. And so here you go. There it comes out of the eye, and then just blot it. Look, there you go.
Boom.
Done. So releasing that pressure gradient. And here I'll just bring the nucleus up. So this is what I do, like you said, for an M6 case. Yeah, same way. I don't mind bringing it up out of the bag. And so here, there's more viscoelastic, okay? I put some extra in.
Thank you.
And I'll just chop this, and it's luckily a Beverly Hills cataract, so it's not too dense. And I can just aspirate it pretty easy. But again, here's the issue. There's the viscoelastic coming out of the eye, so I'll just release it, and the iris will go back in. So again, there it is coming out of the eye. Too much. There comes the iris, and there it is. And so all I do is just lift up on the nucleus or blot it, get that released BSS out. There it is. And then, with no pressure gradient, iris goes back in the eye. But now, of course, the rest of the case, this iris is going to be very mad at me, and this pupil is going to come down now. So now, this pupil will now punish me. So here's another interesting case. There's what we're starting with. And just kind of get your idea what you're going to do here. And we're going to have a fun case here. Not sure why we're in slow motion. Okay, how do you deal with that pupil? Inject more pharma agents. Use pupil expansion ring or hooks. Pupil stretching, quit complaining, get the case done. What do you do in that case? That exact case.
So I always use more epi, like I use Lidofen.
You did it and nothing happened. Now,
right.
Will you do B, C, or D?
So I love the Malugan ring. I usually use that. But it depends what is the patient on Flomax? Like what's the deal?
Pseudoex.
Oh, Pseudoex. Okay, so then you have to decide. Typically, if the pupil doesn't dilate very well, you're suspecting that the zonules are also going to be problematic. So those two things seem to go hand in hand in Pseudoex cases. So in that case, if you're not sure about the zonular integrity, you may want to use iris hooks.
Okay, that makes a lot of sense. What are you, Rosa?
So I do inject the phenylephrine because it keeps the iris more rigid, regardless. If it's a Flomax case, I would put in a ring. Because it's a Pseudoex case and it's a good 4 millimeter pupil, I would just quit complaining and get the case done.
That's kind of my feeling too, but I guess it depends on the case.
Depends on the case.
Depends on what the etiology is behind the pupil.
Yeah.
Because if it's a Flomax iris and it's 4 millimeters, it's coming down.
Right.
If it's a Pseudoex case and it's 4 millimeters, it's not moving. But then be cognizant and just make sure you know what your zonules are doing.
Yeah, I think it's important. For the small pupils, Flomax ones are way different than Pseudoex
Yes.
ones.
100%.
Yes.
Very, very different. All right, let's see what they did here. So there we go. I'm going to do a little pupil stretch. A little bit there, a little bit in the other direction. But you're right. If it was a Flomax type pupil and we're stretching it out,
You're going to make it worse.
it's going to,
Yeah.
right, it'll become worse. So that's probably enough of a stretch. I don't need much more than that. Now I'll use that Osher technique of viscomydriasis, just injecting viscoelastic. And now that's a much more reasonable pupil.
Yeah.
And from this point, I think I can just get the rexes done and call this a day. So there's my forceps are marked off at 2.5 and 5 millimeters. Here's how I do that rexes. I just go, you know where it is. Just use the Jedi Mind Force. So this rex is going to be a little bit bigger than that pupil. And that viscomydriasis that we did is obviously just temporary. As soon as I get the viscoelastic out of the eye, that's not going to last.
Whoa.
So let's see what we do here now. So here, I want that nucleus up a bit.
So gentle hydrodissection.
Gentle, gentle. Look, there it is. Did it. And so now more viscous. My cornea people love me.
Yeah.
I was just going to say that. You keep your cornea guy in business.
Yeah. I would love working near you.
But there we go. It's not a very dense cataract. I assure you the cornea is absolutely clear the next morning. And you can check out if the OCL comes out. Look at this case. I make a para. As soon as I make a para, I'll inject some anesthetic and some phenylephrine and some epinephrine, and look what happens.
Oh, yeah. This is a Flomax iris
Yes.
Yes, absolutely.
100%.
Yep.
How could you tell right away?
because of what it did right there. And the waves, when you inject, it's all those little waves that occur.
So what do I do now? Inject more
Floppy,
agents?
floppy.
Pupil expansion ring hooks, pupil stretching, quit complaining, get the case done.
Yes, you need a pupil expansion ring.
Yep.
So
you
now
know.
for sure you do
Yep.
it.
100%.
What about hooks?
I mean, you could use
Yeah.
hooks, they just take more time to put in. So you could use hooks, and what's important is to do it as Tom Oeding described in the diamond configuration, with one hook underneath your main incision. So you pull the iris down and under, and you do it like that in a diamond. But I just find a pupil expansion ring just so much quicker to put in.
I
me.
agree. Yeah, I do the same.
So is that when you see that sign at the beginning, if it's iris prolapse through the para, like
You're
immediately
gonna have
just open the
trouble
ring.
the whole case if you don't put something in and control that iris.
So now you're thinking like, I'm gonna do choice D, right?
You are, I bet.
No, I am a good student. I learn, I listen. I'm going to put in a pupil expansion ring because you taught me this last year. So here you go. An extra para.
Yeah.
Because who told me? Extra para doesn't ever hurt, right? Yeah, extra para. Done. Get that back in the eye, pretend it didn't happen. And now some viscoelastic. And I'll make our incision. We're sitting superiorly here because this patient got a bit of sill with the rule, and I want to make the incision on that axis. So we'll make the incision here, and yeah, I'll put in the expansion ring, for sure, for sure. And then the way I like to put the ring in, you saw I put a little tiny aliquots of viscoelastic underneath the iris. So there's the leading eyelet, here are the two side ones. I'll adjust the iris here, make sure I get, there you go. I got 3 done, and then there's the 4th one, bam, done.
Nice.
So all in one, get that thing done. Rest of the case is pretty normal. Look, chopping in the bag, see, in the bag.
Woo! All right.
And so here comes the lens going in the capsular bag, end the case. Now the eye's still full of viscoelastic. Here's how I just take the ring out, and you tell me if you do it differently. I'll just disinsert it here. Oh, there's the opposite incision. We're doing paired incisions for a sill treatment.
Okay. Oh, wow.
Yeah, just full thickness paired incisions.
Yeah, I just take off actually the
Distal one?
proximal one. I just remove the one and then reinsert, and then everything else is controlled and comes in. Oh, you do it that way.
And I just grab it anywhere and just get rid of it. Was that okay?
That was very innovative. I don't know if the cornea got scratched.
Oy, 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 guys are tough. Okay, now what is this? How are you going to deal with this case? This is a patient sent to you, had cataract surgery done a year ago. Number one is give the other surgeon the benefit of the doubt.
Yeah.
Because this could have been me operating or you operating, so don't be a hater. No. So how do you address the iris damage? Do nothing and blame the patient for having ugly protoplasm. Hey, I know that one. Recommend a cosmetic contact, pupiloplasty, iris suturing, refer for prosthetic iris implant.
Yep. Pupiloplasty would be great in this case. You can just close that up. The patient will be super happy. I think it'll work great.
Yeah, if you've got enough tissue there
Yeah.
to look like you did to cover up all the little strands there.
Right.
So that's
And when you do
You'll be a
this
hero.
patient's other eye has a cataract. Other eye's phakic with a cataract. When you do that other eye, what's going to happen? Same thing. Iris prolapse, right?
No, not if you preempt it.
Yeah.
No. I'm just saying. But giving the first surgeon the benefit of the doubt. When I see a case like that, I just think the first surgeon had to deal with some really ugly protoplasm.
Right, but you're not.
And so when you do the second eye, yes, you have the benefit of knowing it's going to be really bad.
Yeah.
But still, you're going to face challenges with the iris.
You probably will, but have your plan ready.
No, for sure. My point is, I just want to give the first surgeon the benefit of the doubt.
Always, you never know what the circumstances
Right.
were. I would never say anything bad about a surgeon, only
Except
because,
me.
Well, you. It's so easy with you, though.
So here we go. We got our guest surgeon here doing a good job, doing a little pupiloplasty
Doing
here.
great.
Yep.
And so key on this one too is just again making it kind of match the other eye, having it look reasonable from conversation distance. Now this iris is super thin,
That's the
and
problem.
you can cheese wire through it pretty easily. So you really got to be a little easy. And look, as he's tightening this up, it's creating what looks like peripheral iridotomies there, and that's because just the iris is that wimpy. And the tough part here is these patients with these really light colored irises, they are just fragile
Yeah.
and delicate.
And so for the other eye, you also want to make a longer incision, like DP said in the first cases. You don't want a shallow incision. And in fact, what you might want to do is even a scleral tunnel incision or something that might just go up into the cornea to make sure that the iris doesn't come out. And you can preemptively put an iris hook subincisionally to make sure
that's a
iris
good.
doesn't come
I think a
out.
subincisional iris hook would be a great idea.
They did a lovely job sewing this up with such a thin iris.
Right. So look, and I'll show you the end here. The case looks pretty good. Patient's pretty happy. This is that again that fourth row pupiloplasty. Not a difficult technique. Something you should definitely learn how to do.
Yeah. Yeah, and you should never say anything bad about another surgeon because they may, help you in the long run. You never
For
know
sure.
where your patient goes.
And there's the post-op, pretty
nice.
good.
Beautiful.
Very nice.
So nice result
Good
there.
save. Are we going to talk about how you took out that Mele-Eugen ring?
Yeah, tell me.
Okay, because
Did you love it?
it was so scary. No,
Why?
I didn't. I'm still a little
It
shattered.
was totally planar. It didn't come anywhere near the endo.
No. Okay, so that's completely unpredictable how that's going to fold back in. Sometimes it can actually just pop off and just, ricochet all over the anterior chamber. So just do it in a more controlled way. I think what I do is I just disengage the distal loop
Okay.
first, and then I rotate it out
Okay.
to get minimal pigment release. And then I actually like to put the injector back in, grab the loop, and it just all comes in. I let the two loops come together
That's
like
what I
this
did. I put
and pull
the-
it out. No, you did not. And so this is like very controlled, very predictable. It works. It's very elegant. Instead of just pulling it out of the eye, you know exactly what's going to happen.
But plus sucked it back up in the injector.
Ah,
Okay, da-da-da.
okay. Da-da-da. Okay, here we
Saved
go.
by the bell. All right, so what are you doing in this case? Watch carefully. So we go in here. Look at the pressure. Look. Bouncy. What should we do here?
You got to decompress.
Needle decompression,
Yes,
okay?
yes.
So more viscoelastic. I will listen to you.
But the other thing you have to do is what I call verbal anesthesia.
Okay, wait, let me do. So you said needle decompression.
Yes.
What about Zepta? What about Femta? What about buzzing the capsule fake probe? What about do your regular X's?
No, you've got to needle decompress.
Okay. Is the verbal anesthesia to calm me down?
It's to calm the patient down because I had a case where as I was decompressing, she coughed. So you have to, and then I had a nice Argentinian flag sign. You have to talk to the patient, say we're doing a really important part of the case. I just want you to relax, no coughing, no moving at this point in time as you're decompressing and as you start your rexus so that they don't move. So you need patient cooperation during the case because if at any point in time they move or cough or pressure goes up in the eye, bam, you're done. Doesn't matter what you do.
That's super important. Would you do any of these other techniques besides needle decompression? Zepto, Femto, buzzing the capsule fake probe?
Femto's hard with a white cataract because you need to really increase your power if you're going to.
Yeah.
And you've got to make sure you get through that capsule.
I agree with you. Oftentimes I don't like the Femto because as I start to do it, the liquefied lens cortex comes out, it blocks the laser light, and you get a totally incomplete
That's
capsulotomy.
right. That's right.
I think Zepto tended to work well.
You do can opener type stretches on the capsule so it doesn't go that way?
We're going to find out. That's a good question. He says, do you do can opener? Well, we're going to first do needle decompression. Okay, watch, Rosa. We're going to listen to you. Here's the needle. AC is full of viscoelastic, highly pressurized. I'm going to poke in. Okay, thank you. See what I get for listening to you? This is what I get for listening.
Oh my gosh.
This is what we get. Thanks. I feel. Here you go. 1/4 speed, just so you can live the pain again.
Oh, wow.
Right there. You told me to do it.
You didn't do it right.
Woo! These guys are tough.
So you have to overinflate. What wasn't done here? I know this isn't you operating.
No, it was very highly inflated. The
Was it
AC
No, it
highly
wasn't.
inflated?
It
It was
No.
not. 'Cause
It
you-
was.
No,
What-
it wasn't.
What did you use to? I used like something like a super viscous type of agent, like a Helon 5 type of thing in those
I
cases.
promise the AC pressure was like 50.
No.
Yes, I promise.
Uday,
Professor Baye.
needle decompression, and this is not working. You have to go through the keratocentesis needle, not create a paracentesis and then put the needle.
So he's saying, he says, don't put, he says, just poke in with the needle and make the para as you inject the needle. Don't make a knife para.
Blanco from Buenos Aires color thing. You go straight in with the needle.
Okay, I will keep that in mind.
Good tip.
But here, okay, here's another one. What do you do for the second eye now? Needle decompression, the way Dr. Bias is. Now what do you want to do for the second eye? Same patient, second eye. And the AC was very highly pressurized, I promise. Haters gonna hate, right?
In your hands, I'd probably go and use a Zepto now.
Okay. Okay, what if you don't have it? What if you have a clinic, you don't have any of the fancy toys? How about D? How about buzzing the capsule with the phaco probe?
Oh, no.
Oh, God. Why do you mean, oh, no? That works. Phacorexis.
I described it, actually we described a vitreorexis. We couldn't get through because the capsule was so dense, and we used a vitreous probe to cut.
A vitrector.
A vitrector
Wow.
to cut because it was so dense from chronic uveitis. But I've never done it with the phaco probe.
Really? Let me tell you.
You might be experienced because you get the posterior capsule.
So, don't say that here. So look, on single burst mode, just one burst.
I can't believe you did this.
We're gonna go in here and we're just gonna make,
What are you doing here?
just a little bit of a lighter syndrome there, reverse pupillary blocks. I'm just kind of lifting up the iris to, there you go, to treat that lighters. So we're gonna go in, bevel down, just one little burst of energy. Just
Oh,
done.
Jesus. Oh, you
gosh.
God damn it. Oh.
What? Whoa! We're gonna get a profanity strike on this channel.
God. Can someone get the AED kit?
So now we've decompressed it, and now we'll just get a little baby rexus done here, and then now we'll do a double rexus technique here. So there's a beautiful looking rexus.
So there's a saying, better to be lucky than good.
Yes, exactly. You got totally lucky
Okay, there you go. Nah.
Yeah.
If you would subscribe to my videos, you'd see I actually did another case like this just 2 weeks ago.
Okay.
So here's the IA probe going in there. Just like, this is butter soft. There's no nucleus here. And so now we can just clean out all the lens material. Then we'll put the lens in the bag. Then we can expand the rexus, make it pretty.
Why did you do the rexus so small?
I just want to get it done. I don't want to, as I'm decompressing this, I just want to have, this is the double rexus technique, right? So I do it one rexus, decompress. In fact, this case, I said, forget decompress. I just remove the whole lens.
Yeah.
Clean everything out here. And then at the end, when I get the lens to the bag, or the resident gets the lens to the bag, we'll go ahead and expand the rexus. Just, re-tear it to the exact size you want.
And notice you're using the IA probe to remove this lens.
Yeah, not so
Right?
dense.
Yeah, not so dense, but more controlled.
Right, so I buzzed in with the phaco probe, and then immediately switched to the IA probe.
That's a really interesting method.
You didn't think I was going to give you easy cases today, did you? So no, yeah, this is going to be removed pretty easily here. And you can see at the end, we'll get the lens in. But I've done this, this has been described in the literature. Phaco puncture is not a new technique. It has been described by many other surgeons in the past. It is something that I think actually does work. But yeah, listen, I'd rather do a Zepto if I have that device. Let's do it. So here it is in the bag. Now we can expand the rexus. So I'm just kind of telling them where to cut right, there somewhere. And then we're going to just expand. There you go. Get a cut there on the rexus edge. And then you can expand it and make the rexus size that you want. And then you're done. And the patient has a beautiful outcome. But even in the first case, we have cases where I showed you on Cataract Coach, if you have a white cataract with an Argentinian flag sign, and how can you finish the case? We have all those videos already in Cataract Coach. So we don't. Go ahead.
So the one thing, when you're depressurizing the lens with a needle, you really want that anterior chamber super full so nothing can egress if you do have a para. And the other thing is you want to push the lens down as you're aspirating, so that you actually get the force to be posterior so it doesn't come up and cause the Argentinian flag.
And the other thing is, in that needle, what I like to have is not an air to fluid interface. So I always have my nurses fill the needle with about half a cc of BSS, and I squirt it through a little bit, and then, because a fluid to fluid interface is a much smoother transition versus a fluid to air interface. So you don't get a pop.
Any audience input? What gauge needle did you compress? Professor, just tell me. I'll say it out loud. Okay, 27.
27 gauge.
Here, there is an important physical principle. The reason you get the pop in the Argentinian flag is because the pressure inside the bag is higher than the pressure in your anterior.
Right.
It's because he didn't put enough
So if
viscoelastic.
you put more viscoelastic, you're only creating more pressure, and you're more likely to pop it. That's the reason you go in with a 30 gauge needle.
30 gauge for him.
30 gauge.
Sorry, Professor. Professor. Da-na-na. You can't stop. You can't stop.
It's quicker than your pop.
You can't stop it for you. So watch this case. They're doing this case. Seems like a routine case. My apologies for cutting you off. We just have to stay on time. This is not something I can control. It has to be timed. So there's the Rexus. Looks like a routine case. Chop it with the nucleus, chopped it in the bag to make you happy. It's me operating, not a resident. So then what do you see? Watch carefully. You're like, what is he going to do now? No, it's pretty routine. Oh, what's that?
But I saw that at the beginning. You know, when you started your Rexus,
Yeah.
it was a little wrinkly, your capsule.
Okay. So what's your next move now? CTR now? Hooks to support the bag? Just cautiously proceed with cortex removal, inject triamcinolone, check vitreous. What you want to do?
So, you could actually do a little viscodissection of the cortex in that area. It
Okay.
looks like it's a very focal zonular weakness. You could, depending on how loose you think things are, you can, choose the different options. But I would almost just viscodissect that, use that, take the cortex out of that area last, do the rest, remove it, and then you can put a CTR in, whenever you need to do that. But sometimes you'll trap the cortex in the bag if you put it in too early, unless you use that Henderson modified.
Which I don't have. I think that's a brilliant idea, but
Yeah.
I'm not using
You
one.
can just do a tangential sweep around a capsular tension ring. So I would do a little bit modified viscodissection to get most of the cortex off, put my CTR in, and then go and do, you obviously didn't do that, but, and then go and do my cortical removal. And you just do a little tangential sweep and you can get your cortex. So when you grab the cortex, rather than pulling centrally, you do a little sweep tangentially and then pull, and it just comes up and over.
And I think the key is, though, you viscodissect the
Yes.
cortex before you put the
Before.
CTR in, and put the CTR on top of that cortex in the fornix of the bag.
Yes.
So
Nice.
you don't trap it completely.
So now I can see there's that focal area of zonal loss. There's the equator. Now that's okay. There's a little bit of cortex left. Do I cautiously proceed with more coaxial, switch to bimanual, leave it there, insert CTR, like you said, and then remove the cortex?
D.
So inject viscoelastic now.
And then you can use bimanual IA even with a CTR in, because that also can help you get into the angles that you need to remove stuff.
But knowing you're probably just going to remove it. So when you remove it, you're not going to listen. So when you remove it, just don't have a radial force, as Rosa was saying.
So more
If you do
circumferential
like
or
a
tangential?
hurricane, tangential will be much more gentle.
What's a hurricane?
Like that, Alan Crandall described that
Oh, the
kind of
swirliness.
Yeah, the swirl, to remove the cortex. That's how we remove all the cortex.
And maybe have some visco ready to go in your left hand or your non-dominant hand to get ready to put it into that area to keep it back.
Well, that's nice too. So as you're doing this, have the viscoelastic in the other hand ready, so you can do two things at once. That makes a whole lot of sense. Well, let's see. I don't even remember what I did in this case. So I'm gonna hold the capsule as I take out the last bit of cortex. Tell me if this is reasonable. Just to give it like a little bit of focal support there as I get this last piece out.
Yeah, as long as there's no burr on that spatula.
I
Hope not.
would have used a viscoelastic cannula, but I think it's a good idea.
There you go. And now you said get some viscoelastic in there.
There you go.
Again, another use for that left-hand viscoelastic.
And now CTR. We got some good CTR fun coming up here. So here's how I like to do a CTR. I like to just get that Sinsky in the leading eyelet and then dial it around there. So here you go, getting it there, and advance, 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 and then at this point, easy enough to just release it into the bag and get that off there. Boom, should be easy. Now, again, you're doing an injector, but you're also just doing it, you said, without leading.
Yeah, if you don't want to have two hands in the eye, the thing is that that was a beautiful technique. You just don't want to stress the zonules more when you're putting a CTR in. So whatever technique you want, you can also just do it with one hand, but the key is to have a lot of the CTR coming out before you engage the capsule. So you just put it in with an injector, but again, try to get it all the way over and start it tangentially coming around.
Awesome. So here you see at the end, it looks pretty good. Now watch this case carefully, okay? This is a different case. Watch carefully, taking out the cortex. Looks pretty reasonable, right? Nothing unusual. Surgeons noted some zonular weakness, gonna decide to put a CTR in. So that's again a reasonable approach. So I'm cleaning this up. I'm gonna ask you what to do here. So inject, inject, inject. There's some viscoelastic, bag looks pretty good. And so like you said, don't let anything collapse. There's the viscoelastic, good rhexis, bag looks good. Here comes the CTR. Now tell me, watch carefully, what's going on here? Watch carefully, there it goes again. Looks pretty good, pretty good, pretty good. And, okay.
Oh.
What's that, okay.
Oh, Jesus.
Now what? Now
Wow. Okay, don't let go. Hang on for dear life.
what? Okay, now what do I do here? Is the CTR in the bag? The wrinkles are okay? The CTR gripped the bag? The CTR caused more zonular loss? I have no idea. D, I have no idea. What is going on here? You saw it. Come on, experts, teach me. School me.
I think the bag was not inflated enough.
There's a lot of viscoelastic in the bag.
No, I think when you put your second hand in, you actually had egress of your viscoelastic. If you go back, you can see through your para, the viscoelastic was coming out. So it's getting soft, and I think you ripped the capsular bag.
Oh.
I think this patient had really bad protoplasm.
Absolutely.
Like all of your patients, Uday, where you have a complication,
Wait a minute, so
blame the patient.
Don't hate the surgeon,
Dude,
remember?
yeah.
Be a hater.
I think there might have been a little undiagnosed hole there. Like you might have broken the bag at some point in time, or the patient did have an anatomical.
But it's an anonymous surgeon, it's not me.
Or whoever was operating, there could have been something there, and then when the CTR went in, it went through it, or expanded it.
Okay, so what do you want to do now then?
Take out the CTR.
I don't know.
Take it out. You have a nice anterior rhexis. You're going to be fine.
You sure? You done that
Maybe.
before?
Can you put a bit of viscoelastic in and really see what's going on there?
Well, let's find out. So here we go.
Because it could just be.
I took it out. It's gone. Oh, the anonymous surgeon took it out.
Whoa!
Is that a rent?
I don't know. What do you tell me? What's going on there? So here it is again. Let me show you. Just get this thing and let's just get it out of here. Just grab it and just let's get it out. I don't want it in the eye anymore. The anonymous surgeon does not want this in the eye anymore. Let's get rid of it.
Yes.
Get rid of it.
I think you just have a really wrinkly bag.
Wait, who's a wrinkly bag? What?
As I'm saying it, I'm like, this doesn't sound good.
I don't know what's going on here. I
have no idea. Is it a...
Now what are we going to do? You want to put the CTR back in the bag and use a single piece?
No.
Put the CTR back in the bag and use a 3-piece? Remove the CTR, use a single piece in the bag. Remove the CTR, use a 3-piece and sulcus opticapture. What do you want to do?
D.
But you said just inflate the bag and put it back.
Well, I
didn't say that.
I said inflate the bag and see what's going on. You didn't do that. I didn't know what's going on. So if that's torn, then it's D.
Like, I kind of don't want to find out. I just want to like...
Just be done. So then D is your easiest. Since you took out the CTR already.
Yeah,
just use a 3-piece and put it in the sulcus with opticapture.
And what kind of 3-piece do you like these days? Acrylic, silicone? What's your kind of fastball for these?
Oh, it's what we have, which is an acrylic. Iowa.
Okay. How about you?
Same.
Do you ever do the silicone ones that come out like planar, so easy?
We don't have that option.
We don't have the option either.
But yeah, in a case like this, sometimes you just, every surgery is just an opportunity to get more grief. That was taught to me when I was ready. Right, make it to lunch.
Well, look, you're not really a surgeon if you don't run into
challenges
or complications.
Well, that's how we're here to learn from them. Absolutely.
That's it.
No, so hopefully you're enjoying these cases. These are really great learning points. So yeah, I'm going to do D. Remove the CTR, use the 3-piece in the sulcus, optic capture it. It'll be beautifully centered.
Yep.
Patient's gonna have a fantastic outcome. So here you go. Here it comes, 3-piece lens. This is a planar lens, so leading haptic comes out nice and flat and planar.
So that's a B&L.
Yeah, and then the optic comes out nice and super flat too. Boom, totally planar. So no, I don't want to twist around inside the eye. Let more, if there is
That's
vitreous.
nice.
It's
Yeah.
a nice lens. to
And then
put
just
in.
dial this in nice and easy, and then optic capture it, and then we can finish up the case here.
So which lens is that, Uday?
That's a B&L LI61.
Got it.
And so 3-piece silicon lens, 6mm optic, just a monofocal lens. And then just making sure I got it where I want it, and then get that optic captured behind the rexus. And of course, this is going to have a nice, very stable outcome. Seating up the incision here at the end too, prior to moving viscoelastic. I just don't want to have any vitreous prolapse coming around the edge of that. And so I want the nice, maintained anterior chamber. So taking out viscoelastic now. Again, I'll go a little slower on the parameters, taking out more and more. Again, if there is, you think, significant viscoelastic retained behind the optic, leave it be. We can put the patient on some Diamox later, and the patient will be fine. So sealing up that incision, and then the outcome ended up being really nice. Patient was super happy. And yeah.
Did you figure out the etiology of the wrinkles?
Interestingly, I just must be more zonular loss, but the next day, there's no vitreous prolapse. The next day, the bag looked intact with the slit.
Yeah.
So maybe I didn't need to do all that. Maybe I could have had another alternate approach. But that's what I chose to do at the time. Sometimes you don't know, right? You look there at the slit lamp, and those wrinkles on the posterior capsule scare the heck out of me. So,
I think it's an equatorial circumferential rift. I don't know what causes it.
equatorial circumferential, maybe.
Yeah, and then the ring expanded it, and so it went from 1 clock hour like 3 or 4.
Could be.
I've seen a few of them.
We'll take your question in 33 seconds.
Speak fast.
Well, I think this is not the best approach. In long term, once you put a lens into a capsular bag, even if you capture within the capsular excess, the fibrosis will dislocate this lens in the course of time. And you have to take care that the vector forces in the capsule should be evenly distributed in the bag. So it's a good idea that you put a capsular tension ring in.
3, 2, 1. Thank you. I appreciate it. Great sentiment. Last case, pseudoexfoliation. All right. Here's a re-op of a tough pseudoexfoliation case. So the patient had a prior surgeon go in the eye, made an incision, put in a pupil expansion ring, and now it's time for you to do the case. Surgeon aborted that case because the AC seemed awfully deep. Even though the pre-op AC depth was 2 millimeters, on the table it was 4 millimeters. So what is your game plan now? Plow right ahead, don't trust the previous surgeon? Let's have everything ready. CTR, CataractCoach AVIT. Stop and look at the pre-op exam or plan for Yamane. So again, the challenge here was the patient pre-op. The patient has about a 2 millimeter AC depth on the OR, in the slit lamp, maybe 2.5. On the OR table, the AC depth is 4 millimeters.
Okay.
When the patient's supine. So what does that tell you?
The zonules are loose.
Right.
Has
Yeah.
the patient had a vitrectomy before?
No prior surgery other than the patient was taken to the OR for cataract surgery about a month ago. And a pupil expansion ring was placed. Surgeon then decided just to abort and took the ring out.
No other, just did the incision in the
The patient has a para, a main incision, and evidence of a prior pupil
What's the
expansion.
axial length?
Don't do the lights like that. You're hitting the light switch with your elbow, buddy. Could you help us? Hey, AV people. My friend, can you turn the lights down? Thank you. Yeah, someone touched the light switch there with their elbow or something.
What was the axial length?
Normal, 23.
Okay.
23 millimeter axial
I
length.
would do B. I'd have everything ready to go, but know that you're going to run into issues, maybe.
Yeah, when your AC depth is shallow, with your biometry, and then you go into the eye and it gets much, much deeper, the zonules are a bit loose.
Well, Rose brought a good point. So shallow AC, but normal axial length. Well, you asked the axial lengths. You're right. So loose lens iris diaphragm. And so sometimes hard to detect that phacokinesis. Sometimes we'll see this on the OR table. You'll see a lot, like an AC deep where the patient's supine, and then a lot of wrinkles with the rexus.
Yeah.
All kind of very important, intraoperative clues here. And so in a case like this, we definitely, in Pseudoex, I don't mind doing a pupil stretch, and I tend to want to use a CTR, so we'll do that too. And then in this case, we ended up just using the same incision that the surgeon had from a month before and just open it up. So here's some viscoelastic. I put a lot of like 10% phenylephrine ahead of time, really got the patient dilated. And you can see there's a lot of pseudoexfoliation material there. I'm just opening up the incision with this cannula because the incision was already made. This surgeon used a 275 incision, so we'll just stick with that. You can see there's a little wrinkling there to the capsular bag. So we'll get a nice generous rhexis here. I've learned from you, DP, don't make a baby rhexis in a pseudo-X case because they're going to get phimosis later. So we'll get a nice generous 5 millimeter rhexis, nicely using that pseudo-X as the guide.
Yeah, that was convenient.
Right, and then so we'll get this nucleus removed pretty easily. Definitely going to put a CTR here too. Now how are you going to do it for nucleus removal? Divide and conquer? Tried and true, it's all they do. Stop and chop, works well every time. Phaco chop, horizontal vertical. Or flip it out of the bag because I told you to.
You're going to flip it out of the bag because that's all you do.
No.
Yeah.
What am I not hating?
I love stop and chop. It's my go-to procedure. I always like to just get one groove. I divide it in half, and then I can get that lens out. It's in 2 pieces.
It's easy.
And I do a squeeze chop.
Right.
And it's really gentle and works for me. What would you do, Rosa?
So I would do my technique, which is a pocket chop, which is kind of akin to a phaco chop. You just got to make sure you don't put any undue forces on the lens. So you've got to be able, so if it's soft enough with the pocket, you can do a soft chop under sculpt and just use your second instrument to slice and crack the lens into 2 halves. But the key here is to do all your chopping in the bag before you start removing a piece, so that you always keep the tangential force equal around all the zonules. If you start pulling pieces out, you allow that bag to collapse in those areas. So chop everything out and then remove everything. And again, in these pseudo-X eyes, if I'm worried, I don't let the eye decompress.
Smart.
And the other thing is I always do hydrodelineation. So I keep the epinucleus there supporting the bag as I'm taking the endonucleus out, which is a really helpful strut.
So
see, I told you. You're so predictable.
You say it like it's a bad thing. Good thing.
He's a man, so.
Whoa! You're clapping for that? What if I said the opposite?
It's not true, the opposite. So.
Hey, come on now. So yeah, I'll chop, more chop, get this thing out. So look, there's 0 stress on the bag. How good is that?
Just ask the corneal endothelium.
The cornea is perfectly clear the next morning.
No, I'm totally joking. You know that.
Perfectly clear. Phaco power modulations, beveled down, very little energy. Clean it up pretty nicely. Now here, I think I'm just going to do some cortex removal. I'll watch carefully, but I think there's no focal area of zonular loss. It's kind of just global zonular weakness here. Yeah. Now it's not super weak on the zonular area, zonular support, but it's reasonable. As I take the cortex out, I'm looking at the rhexis edge just to make sure the rhexis doesn't move.
Smart.
So then the rhexis is really not moving. So I was like, wow, this is not as bad as I thought. I was actually going in here a little bit more trepidation because the previous surgeon who I respect a lot said, no, this is a tough case. And so we're going to put here, now learn from you, look, visco dissect the cortex, fill the bag. See, I learned.
The other key here, just while we're waiting for you to put the IOL in, is just
CTR.
CTR, sorry, is to also make sure there are no nuclear fragments under these irises.
Oh, very good.
To make sure you're not surprised the next day.
Absolutely.
And that goes for floppy irises as well, and don't ask me how I know.
So do you lift the iris?
I do. Yeah.
So at the end of the case, use like the chopper, lift the iris.
Lift the iris, and I kind of sweep tangentially with the IA to make sure, do a little wiggle in the middle to try to get the forces to bring anything to me. Otherwise, you can lose a piece under the iris, especially these honey-colored irises, the blue-orangey irises, and it can you're going to have to go back in and take it out.
What's your lens choice here? Hopefully not B, right?
I would do a single piece in the bag. You have a CTR in, you're completely stable now, and just do the lens that you do.
Yeah, I would do a single piece acrylic IOL in the bag.
Yeah, it's basically what I'm going to do here too. But although if it's really bad global zonular weakness, I think E is really a neat option too.
Yes.
Because that really prevents the anterior capsular rhexis from phimosing down.
Right, but your zonular laxity was not so severe here.
Right, so here I think it's reasonable to just put the single piece in the bag. But yeah, if you have in your really bad global zonular laxity, a CTR in the bag, and then a 3-piece with optic capture, happens in sulcus, is like so beautifully
Yes.
stable.
Would you
Yes.
do a toric in this eye if they had astigmatism?
Yes, I have no problem doing a toric here. And then you kind of balance it out. Will the patient come back later with complete dislocation of the bag complex? Maybe. But luckily the patient's already 90, so time's kind of on your side. I'm being honest. Time's on your side, not the patient's side. So here's what we do. And we're going to wrap this up soon. Here we go. Here comes the lens. So yeah, just a single piece. I think it's, let's see what lens it is. I think it's, it's a non-toric. So just monofocal lens, non-toric in the bag. There's the Rexes. What seemed like a mega Rex is just about perfect.
Perfect.
Beautiful.
And then we'll just finish it up and call it a day. And we can put some triamcinolone in the AC to make sure that we don't have any excessive
And
inflammation.
so the other thing I do in these cases to look for chips is that after I do complete removal of viscoelastic, I actually put the ioprobe there, depress from the para, so you decompress the AC but leave the lens where it is, and so any pieces can come forward, and then increase the irrigation again. So you kind of cause a little turbulence to see if you can get some pieces to fly in.
Oh, just kind of like high flow to push everything around.
But you decompress, right? And then it comes. But you don't shallow the posterior segment, right? You keep your
Gotcha.
eye probe there, keep the lens in place, and then just kind of do some fluid shifts.
So this patient's other eye, how would you proceed?
Same way.
Just kind of same way?
You did a great case, Uday. Congratulations. It looks
It took me
beautiful.
8 cases to get a compliment. All right, thank you. So, end of the case here looks pretty good. Again, I like to put a little extra triamcinolone here. I put triamcinolone, I'll put a little bit of preservative-free moxifloxacin as well for endophthalmitis prophylaxis. And this patient's going to have a real nice outcome here. So there's checking the incisions.
So with all joking aside, Uday and I have been friends for over 25 years, and Deep as well, we've all been friends. So we're just joking. Uday is probably one of the best surgeons I know.
Thank you.
Of course.
But it's the best way of learning. I mean, the best way is to put it all out there. And the difference between a mistake and a lesson is you learn from the lesson. So I want to make all these cases lessons. A little LRI there so we can fix it. Probably a half dot for a sill. And everything looks great. Again, normal pressure. Pretty happy here.
Beautiful.
Wonderful.
All righty. So any audience questions here, our last couple of minutes? Beautiful. We'll take any audience input. Yes?
I have a question about your triamcinolone.
Yes.
Do you use catalog?
So triamcinolone, we use catalog, and I filter it and clean it, and there's a video on CataractCoach.com where you can see how to do that. If you don't, it's actually important questions. If you type, every day when I go to the OR, the beginning of the day, I just go there early. I'll prepare it myself, and I show how to do it. I even show the part numbers of the exact filter I use. Again, if you go to CataractCoach.com, the website, not just YouTube, go to CataractCoach.com, type in keyword triamcinolone. It'll come up, and it's an easy step-by-step video of exactly what I do, and I show the part numbers of all the filters and all that stuff too.
Thank you for all of your teaching.
Oh, thank you.
Every day of the year.
Yeah.
Cataract Coach.
Thank you. Thank you. And remember our podcast, please. If you're not a subscriber to our podcast, best podcast in all of ophthalmology. Every Sunday, these guys have been on it, an hour long. You will love it. And please follow me on social media. Thank you guys. Yay. Awesome.